Good morning, everyone. My name is Chad. I work at the Vascular Institute. I am the local sonographer, so anybody can see me for anything they need. My talk is going to be, is there a role for the vascular sonographer in planning the access approach in the OBL? Kind of a mouthful. When I first read that, I was a little bit intimidated, and sometimes when we think about being a vital role in surgery, it can be intimidating. But I thought about every patient that we see is on a journey, right? Maybe a short, maybe long, they take different paths, but every patient that comes in has come in because they have a problem, a complaint, a wound, something that's decreasing their quality of life, and we want to take them on whatever path that it needs to get them back to a better quality of life. So I wish I had something to disclose, but I don't. To start off, as we were reminded this morning, sonography is stressful. It's a difficult job, right? We have a lot of patients and sometimes not a lot of time to do it. So we can tend to get going fast. And when we talk about learning something new, sometimes it feels daunting because we think that means more work. And we don't want to do more work because sometimes we don't have time for that. So I'm going to talk a little bit about taking the right pictures does not always have to involve taking more pictures. We are really the last line of defense. When it comes to ultrasound, if we miss something, the machine isn't going to pick it up for us. So I like this quote. It says, "Productivity is being able to do things you were never able to do before." So we can be productive without killing ourselves. Critical thinking is a big part of the surgical planning when it comes to ultrasound. Critical thinking helps us look at the same pictures that we already take, but maybe we look at them from a different perspective. If we think about the vessels that we're looking at, and we think about how the surgeon can use this information, then we can use the same protocols that we're doing in a different way so that we can be more helpful. Now, to start, we think about the general questions that we need to answer with an ultrasound. First of all, where is the disease? Is it in the thigh? Is it below the knee? Is it in one leg or both? We need to figure out where the disease is so that we can start to figure out how to fix it. Second, how extensive is the disease? So if somebody has a short segment occlusion versus having disease throughout their whole leg, it's going to be a different approach surgically. And then, how severe is the disease? Lots of patients have plaque. It doesn't mean that they have to have surgery for it. Sometimes a patient will be near occluded, or it'll be occluded, and that can be different. So when we're looking at the leg and we think about big picture, think about these three questions. Where is it? How extensive is it? And how severe is it? These are questions that if we get answers to, we can really help our surgeons figure out what they want to do. Okay, so we're starting our journey to the successful surgical planning. Now, I put start small and get bigger. This doesn't mean that we have to start at the foot and work our way up when we're scanning, but when we think about it from a surgical aspect, their preference is usually to start or get access at the tibial arteries. Posterior tibial, anterior tibial, maybe perineal. So when we're looking, sometimes by the time we get down to tibials, we think, oh man, these are hard to see, I'm tired, and sometimes our image quality can suffer. But if we think about the fact that they would like to use those tibial arteries, we can try and answer questions about the tibial arteries. Again, not working harder, but just thinking about what we're seeing when we're taking images down there. Then we also have superficial femoral artery they can access, common femoral artery, the iliacs we're going to talk about, distal aorta, and then the contralateral common femoral and iliacs. Why do they like to start with the pedal or tibial access? Well, primarily it's safer for the patient. They're putting a smaller hole. There's less trauma, less injury. We have reduced contrast, reduced bleeding complications. It promotes early ambulation. You think about a much smaller wound, You can heal much faster. And it's safe for the care of PAD and CLI patients, which is good for us because we see a lot of PAD and CLI patients, right? So if we can, we think about starting at the tibial for access. Tibial arteries. On the left there, we have a picture of anterior tibial. Think of how small that catheter is, how small that hole is. And then on the right, how small that bandage is. We think about that patient might be able to recover a lot faster because they've had less trauma to their body, and it's a little bit easier. So what do we need to think about when we look at tibial arteries? Well, like I said before, occlusive versus near occlusive disease makes a big difference. Getting a wire through a mostly occluded vessel is different than a completely occluded vessel. So we need to adjust our gain, make sure that we're getting sensitive flow, and try to see if it's actually occluded or just mostly occluded. Then, is it one vessel or is it multiple vessels? If it's only one vessel, that's going to change what they do to change it or to fix it, and it can change what they're going to do to access it. And then is there heavy plaque, heavy calcification, like a diabetic patient, things like that that make it hard to gain access to go through the wall? So that's something that we want to notice. Now I just mentioned that perineal artery, it may not be the first preference, but it is a viable option. Like Tina showed in her case, sometimes AT and PT are both occluded, and perineal will still be open, and they can use that for their approach. All right, so tibial arteries. One abnormal waveform at the ankle level doesn't mean you have to interrogate every segment of every tibial artery. This is where we try and use our critical thinking so that we're not adding work, we're just working smarter. So I put this acronym on there of STOP. When we first see something, let's say anterior tibial artery is triphasic, posterior tibial artery is monophasic. So we stop for a second and think, what are those waveforms telling us? It tells us that the anterior tibial artery is probably fairly clear, and that the posterior tibial artery probably has some disease. So when we proceed, we observe what's normal, what's abnormal, and then we can scan only what is needed. So in that instance, we would probably take some more pictures of posterior tibial artery, see if we can find the disease, and anterior tibial artery, we're probably fine to just say there's no disease there. Then we continue up the road, right? So the picture on the left, there's common femoral, and then this on the right is superficial femoral artery going retrograde. So if a patient has superficial femoral artery occlusion in the thigh, sometimes they can go from common femoral, sometimes from superficial femoral, sometimes both to get at a lesion. So that's just something that we can think about is when we're scanning through, think about some of these points that our surgeons use and what's the disease look like in these areas and in between these areas. And then popliteal artery isn't generally an access point, but don't skip it. We still have to look and make sure that there's not a stenosis or an aneurysm because either one of those things could change the overall plan that they have for intervention. All right, now we're going to talk about common femoral artery waveforms. So we have multiphasic waveforms, which are triphasic or biphasic, and then we have monophasic waveforms. The normal triphasic waveform has three components. So we have this rapid antegrade flow, comes up to a sharp peak, then comes down, and we get reversal of flow during early diastole, and then we have a little bit of slow antegrade flow during late diastole. This is what we love to see when we put the transducer down, right? This means that the patient probably has pretty good flow, not too much that we're going to have to worry about in this area. Then we have biphasic flow. Very similar, but we've lost that little third component during diastole. So we just have reversal of flow during the entire diastole, and the triphasic portion disappears. So to note from these, triphasic and biphasic are considered fairly normal. What we have to worry about is if we put the probe down on common femoral and we see monophasic waveform. Monophasic, look at the difference. We don't have anything going below the baseline. It has slow upstroke, a blunted peak, and then the diastole continues above the baseline. So in a lower extremity, monophasic arterial waveforms are always abnormal. And they're often seen downstream from a stenosis or maybe multiple stenoses. So if we see this at common femoral, we gotta think that's downstream from a problem. We need to work our way up, right? So monophasic waveforms at the common femoral level are indicative of inflow disease. Now we've covered the leg, we might need to go up and take some pictures of iliac arteries and distal aorta. So what are we looking for in iliacs and aorta? Same thing that we look for in the leg. We want to look at the waveform morphology and see, is there a change? Do we see triphasic waveform at common femoral and then monophasic at external? Common iliac and then monophasic at external iliac? Because that can tell us if we see that waveform changing, that might be the location of the disease. Then if we have unilateral disease, that means we need to check the contralateral side. So for access, sometimes the surgeon will go in on the opposite leg at common femoral, up the iliac, through distal aorta, and then back down to get to the lesion that's on the side that we're interested in. So a good thing to remember is if we have monophasic waveforms at the common femoral level, work our way up and look at iliacs and also look at that contralateral side. And that can help them to determine what they need to do for intervention. All right, working with your surgeon. This is my first day at the Vascular Institute. Dr. Lassar gets younger every day, and I'm glad he got me to cut my hair. So each surgical group has their own preferences, right? We may have different levels of contact with our surgeons. Sometimes you might be able to work with them every day. Sometimes you might not be able to see them or talk to them at all. But over time, we need to try to find out, however we can, what is helpful to them. Maybe we can talk to them. Maybe we can ask, what pictures do you like? What approach do you prefer? Is there something that I can do to help? Or if we're really lucky, maybe we can actually go in and watch a procedure or two, really see what they're doing, and then it can help a lot of things to make sense to us when we're looking and trying to find the answers. But if we don't have that, be detailed in your reports. So maybe we don't get to talk to the surgeon, but we think about the big picture. We're the ones who are giving them the information, and we have to try and make it down into one page when we've taken maybe 50 pictures. So our reports are really our communication when we don't have face-to-face communication. So it's important to think about the details. Maybe there's a drawing, maybe there's descriptive words or different things that you can use in your report, but think about getting the report as accurate as possible because that can really help, especially when we don't have the face-to-face contact. And then the most important thing is don't give up. It's not easy to do some of these things. It's hard to find iliacs sometimes. It can be hard to find perineals sometimes. But it gets a little easier with time, and then we'll feel a little more comfortable with it as we continue to do it, and that will really help. So in summary, it may seem like it's intimidating, right? We're standing at the edge. We're the ones who are the last line of defense, and we're going to help determine what their procedure is going to be. But we can bridge that gap. We have to use our critical thinking. We have to start off with those small arteries, look at the big picture, see if we can solve that puzzle and decipher where the disease is, and then we work as a team, and we can achieve success for each and every one of our patients. Thank you.
Thanks, Chad. Chad is one of our techs at Vascular Institute of Chattanooga, and I want to give him a big thank you and shout out to all the help coordinating for all the speakers and everything that goes in addition to what we do every day. So now we have Tish Poe. Tish is, if any of you have been around vascular ultrasound for any length of time, you know her name. She has extensive background and one of my good friends, and I'm going to let her tell you a little bit more. She's moved around a little bit and is now doing contract work, consulting and education, and I've learned a lot from her. She's come into our lab and helped us over the years. She's been very active in SVU and now's been very active with the foundation research, and so I'd like to introduce Tish Poe. She's going to be talking about physiologic testing.
And our clicker's right here. Hi.
Here.
Yep. So back forward, and we have a
So
pointer.
now we've got, yeah,
Oh, and you do have this here. Good.
got it.
Where's the pointer? Right here.
It's right there.
Gotcha. Excellent. Have to get acclimated to my environment here. But thank you very much for the invitation to speak. And this is a wonderful conference, and I applaud you for expanding it out into including the sonographers and technologists in the laboratories. So I'm not going to spend any more time with that, except as a member of SVU and one of the people who've been raising money for the foundation for a long time. When you renew your membership, consider giving just $10 or something like that to the foundation. It will help us. All right, so I do have a disclosure for the first time in my entire career, and I am in a consulting relationship with Invino Medical, and if you would like to look them up, you certainly may, but I've been consulting with this company now for several months. Too often, when we talk about physiologic testing, and if you look at the top, I say yes. We do still need to do some physiologic testing work, as has been said many times in this meeting, just in our introductions to these topics. You have to use critical thinking, and things need to be done correctly for us to have correct information. So too often, and I think you may agree with me, both in the schools and in actual practice, this is looked at as kind of a test requiring low-level skills. Anyone can do it, and it's something that is just almost a throwaway many times. Get the ABI. With waveforms. But balancing the information that we get from that test is what's important, just like has been said about duplex imaging. So the patient history will help direct you in what you're doing and how far you go in the toolbox that you have of physiologic testing options. So how do they look? What is their history? What is their presentation? And again, pressure measurements should not be taken immediately when the patient gets on the stretcher. So we are busy. Hi, how are you? Let's get the legs exposed, and boom, we're taking pressures. You need a little bit of time, the patient does, for them to reach a good plateau with their pressures. And then during the test, do you think the pressures may have changed? Sometimes we have to go back and repeat the pressures, especially, and I'll say this several times during this talk, if the waveforms are not consistent with the pressures that you get and with the patient history. Think about it, or at least make notes in your reporting. So waveform acquisition, how, when, where should we be taking these waveforms? And I come from the generation before we did a lot of duplex. So yes, physiologic testings were done more extensively. All segmental levels, we've kind of tapered that off. There are times where that may be needed and not. And one of my hills that I get on in a soapbox kind of way many times is exercise. We don't use it enough, in my opinion. So with that, balance it all together. You get out of balance, the whole thing falls down, right? And you need critical thinking. We all need to have this as every part of every test. And I won't read out this slide to you, but we know that there are physiologic testing advantages and disadvantages, and that duplex is often going to be something that you're going to be adding to it. if the patient has disease. So when we look at the LCDs and we look at all those billing things that come back to haunt us many times, there is, and I think reasonably, a mandate to find out first, should we be employing the more high-level, more expensive testing, whether it be duplex or CTA or angiography or whatever else we're going to, that you need to have evidence for disease before you advance into the next testing levels. And 0.9 is often given by many different algorithms or interpretation criteria that are used. I don't like 0.9 personally. I think 0.95. I see a lot of people at 0.9, 0.91, 0.92 who have disease, but at rest they're pretty well compensated. So establish an algorithm, and this is something that oftentimes I hear, well, we have to have a separate order for each thing. Every place is a little bit different. Can you have conditional orders? Are you expected to follow an algorithm? And I would say, being in the VIC labs and talking with Tina and Dr. Lazar, they're expected to critically think through what needs to be done. Get me the right answer. Tell me what's going on. We heard from Dr. Lazar. So this is just an example of an algorithm. And again, I like using 0.95 and above, and that's not just me personally. It's backed up by other research and all, but choose a level that you're comfortable with and that makes sense when you correlate with other studies. So whatever you get in terms of your CW Doppler waveforms, PVR waveforms, in some parts of the country, the whole test is called a PVR study. In other parts of the country, it's called just get your ABI. At other parts, it's called a SEG study or a pressure study. But there are advantages to CW and there are advantages to PVR. If I'm a CW person, which I tend to be, there are times where I might go to a PVR for certain reasons. So know what you have, and if the exam is abnormal, you may want to just get a common femoral artery waveform, even if you're doing an ABI at the ankle single level. And your protocol could specify a PVR. So do you have a normal exam? Does the patient even describe claudication? Do they describe anything that goes along with arterial disease? If they have claudication symptoms in a normal resting study, I say exercise them. And if the pressures don't drop, and again, you need to look at the patient's condition. And if you think that they have falsely elevated pressures, don't exercise them, because it'll lie to you before the exercise and it'll lie to you after the exercise. If you have abnormal exam results, so again, what range are you in? Should I even consider exercise? Are there contraindications to it? Do you have a treadmill available, or are you going to use toe-ups, which can get kind of a bad rap out there, but I know companies that have used that a lot, and if it's done correctly. Again, if my patient can't exercise for any length of time, maybe it's not a good test. Maybe it's not something that will give us good results. So then you want to establish what are our ranges. And I think with TBIs, even when I've researched this for looking at criteria charts in practices I've been in or consulted with, the literature's a little thready out there about TBIs. But this is just an example chart that then you want to compare to what your outcomes are. And see if, when you're looking at, if you think the toe pressure is very low, what is going on? And look at the feet and talk to the patient. So pressure measurements, you have to do this all correctly. If you don't do it correctly, you're going to get poor data and it won't work well. So let the patient rest. Lay them down first. They want to sit up to talk with you. No, lay down, and get their history, take a look at them, get things set up. We often are not putting on full segmental pressure cuffs at this point. How many people in our group here that are live with us, how many of you do a full segmental pressure study routinely? And I see nothing, right? We're doing ABIs at the ankle, but maybe you do want to get a thigh pressure at some point. So don't say, I never do it, or that's not how, I've not been trained. Think about how you would do that if the doctor wants a thigh pressure or above the knee pressure. So the cuff, is very important too. Is the cuff, if we basically use a narrower or wider cuff, does it change anything? And yes, it does. If you use a narrower cuff, it's going to raise the pressure relative to a larger cuff. All right, my patient, and hopefully they don't do all of the above in this second one, but they fall asleep or they start crying. They're telling you something that preceded their visit or happened in their life recently. They need to go to the bathroom, right? Halfway through your pressure study. They get anxious. What do you do? So hopefully not all of the above, but I may have had a few of those. Repeat the pressures. I'm sorry, but got to do it again. Maybe the pressure changed, and now I'm comparing the arm pressure to an ankle pressure that is not the way to go. Is the cuff wrap important? A tighter cuff wrap will lead to a higher pressure, so you want to be sure that one is similar to the other. Honestly, if one leg is grossly swollen compared to the other, I will note that because that's going to change things. So again, it's a thinking study, and we've already talked a little bit about the waveforms, and I thank Chad for including that. This paper came out in 2020. It was a big think tank of people who looked at what consensus can we come to in terms of how we name and label waveforms. I have worked in a number of labs. I worked over almost 25 years in southwestern Virginia in what became the Carillion Health System. And then I've been a wanderer, as my children and other colleagues would say. And I've gone to different places. After they graduated from college, Mom took on a couple different areas of interest. So this paper is very good in helping us get down to how do we label waveforms? And I've been in places where, no, we don't call it this, we call it that. And of course, the one that has been one of the most difficult to categorize is a monophasic normal waveform component, rapid upstroke kind of waveform. What does that mean? And that kind of was one of the things that led to this very involved paper that came out. So I'm just going to highlight a few of these things. When we talk about, and there are venous waveforms in there as well, but when we talk about arterial Doppler waveform, and this is Doppler, not PVR, interpretation, there are 4 things that were identified as key components that you see listed here. The direction, the phasicity, the resistance pattern, or I'm sorry, 3, not 4. And then there are many different modifiers that can be used, because if you say, again, this phasicity has been a huge one, and maybe ignoring resistance patterns. Then you have other terms that are used as modifiers. And when we look at something that has been, again, a very difficult thing across the board, do we call it spectral broadening? Do we call it turbulence? What do we say? Filled in waveform. We can go on and on, but what are the terms we want to use? So this is what has come out, and basically in spectral broadening, that stuck. And of course, spectral broadening, filling in the spectrum, having not just laminar flow right down the middle in a vessel that's big enough to put a small sample volume and catch center stream flow. If the sample volume goes wall to wall, you're going to have a filled in spectrum because it will be fast to slow across it. But many terms have been used in that. Now, if we're using an analog waveform, CW Doppler, we don't talk about spectral broadening, and we can say that this looks turbulent. These were waveforms that were obtained after exercise. This came from Eastern Virginia. Dr. Lassar knows that group as well, and often after exercise, we would get a common femoral artery waveform, even if we were just doing the ankle level full exam, because it could point to, do I need to now go on to iliac studies? Or do those look normal but hyperemic after exercise? So there are many ways to use these tools, and again, this term multiphasic was heavily fought into, the language. Do we say tri, bi, and mono, which were auditory things? We can see them in the waveforms, but the last component that Chad mentioned in terms of not having that third component, the above or going, forward, reverse, and then forward again. The forward again is often arterial compliance, whether the artery actually snaps back and whether you have a compliant artery that expands and then pushes it forward again. So multiphasic became the term, to monophasic, but monophasic has often meant very dampened, delayed. If you say it's monophasic, it's a conclusion that gets jumped to that is grossly abnormal. But we see hyperemic or all in one direction, normal waveform component, rapid acceleration waveforms. So you need a descriptor with this besides just it didn't cross the baseline. Over all my now 40 years in this whole issue of what we do in the vascular laboratory, this has been a big deal. And I've argued with folks over the years, can someone just say, is phasicity related to the baseline or how many times it moves up and down? So this was baseline, is what has been the consensus. And then you have resistive patterns that can indicate you have a downhill obstruction or maybe vasospasm where the downstream vessels are tightly closed. And you can model this for students or for in your lab just by making a fist and listening to your brachial artery. And many of you may have done that you close off that distal circulation, you're going to get high resistance patterns. I won't read this to you, but there is a high resistance, a normal resistance, and then we get these that you go, just like phasicity. What do I call this? So there's an intermediate resistive pattern where it comes down to the baseline, but it doesn't go below the baseline and doesn't actually change direction. So all above the baseline, changing speeds is not the same thing as changing directions. And this was something that I just feel good having terms that maybe we can finally start calling it all the same thing. So a low resistive waveform also may be hyperemic. Post-surgery, you may have a rapid upstroke, an improved upstroke time, but you have all the flow above the baseline. So if you look at this paper, you will find that there are very good descriptive terminology, but also what we all love to see are example waveforms. So, I encourage you to look at it, think about it. So we'll look at a couple of cases with this. So this one was one that was done, and the physician wanted a full segmental study. Now, we did not do segmental pressures. Thigh pressures we could talk about for a couple of days as to how those may not work out so well, but segmented waveforms and pressures at the ankle. And the patient had no symptoms related to claudication, so we were done. Okay, we were done. Now, if they wanted exercise, you would put that in. This is one with PVR waveforms. So again, what is a PVR? Do not use your multi-monophasic things with this. We do look at the rise time. You want to set things at the same gain if you're doing PVRs. And you want to look at the waveform shape, but don't use the same descriptive terms you do with the others. And what is our most important feature besides a good acceleration on a PVR waveform? Anybody here of PVR? The most important feature on a PVR waveform is, we have a very quiet audience, dichrotic notch, okay? And if you have to imagine that there's a little elbow of a notch there, it's not there. So when you look at these, you have some very broad categories, but this is global perfusion under the cuff. It's not vessel specific. And I just give you some examples that you can use. This is both for PVR with the cuffs and with PPG on the toes. Now, what does this waveform indicate? All of those who took their RVT exam recently or like me a long time ago, what does this indicate? It has a peaked or nippled top to the waveform. Describe. I have crickets here. Oops, I didn't give you the answer. Yes, what is it? It's vasospasm. When you see an anacrotic notch above, and I have had a few upper extremity studies where every one of them is peaked. So just running through a little bit of the cases. So this is a patient who had a recent MI, did the pressures and waveforms, did not exercise them because they had cardiac issues. One of the things to ask yourself all the time is, do the pressures I'm seeing match what I think about the waveforms? And if they don't, You need to do something to address that, or at least say in the report, I have discordant information. How many of you think that the 0.62 on the left side of this patient, that the waveforms look like? You look at the waveform, you'd say, oh, if I were going to bet, I'd put it somewhere in the 0.62 range. And the other side. Now, if you have perfectly normal pressures and waveforms that look like the left side here, then you're going to want to say that maybe that is a not completely non-compressible vessel, but it's in that, again, they don't go from compressible to a hunk of rock overnight, that there's something wrong. I have poor waveforms and I have normal pressures. In that case, I would believe the waveforms, okay? Now, so if you look at something like this, and we can see that there is a major problem here. Again, these are waveforms all the way down, but even if you just looked at the ankle level, there's a problem. Now, this would require, then, you would go to duplex. Boom, you're there. You want to go to duplex with this. We have this one, patient who has 3 blocks walking distance, and I don't like to use blocks so much as maybe saying, can you picture a football field, which maybe they can, maybe they can't, but blocks can be highly variable in terms of their distance. But what causes it? What if you walk faster? What if you walk uphill? Do you get into any problems? So how many think the right leg looks really good? Come on, raise your hands. I need some interaction. How many think the left leg looks not so good? Okay, that's pretty easy. Now, this is a patient that if you just did the ankles and waveforms, both of them dropped. So this is where I look at exercise as giving me a very, very big clue. Both of them dropped, and significantly. I'm a fan of exercising, okay? So thank you very much for inviting me to this conference. I hope that some of these cases give you some examples. And again, if you don't do full segmental waveforms, most of us don't do full segmental pressures anymore. But use the information you get in combination, and critical thinking is the key. When do I go on? When do I stop? And an initial exam with a PAD patient, I think Tina and all the other folks here would agree, we don't know what we're getting into. A brand new patient that's being referred with possible claudicant or PAD. So, Chad.
Are there any questions from the audience? So Chad made a mistake. He gave me the microphone, so now I get to ask him a question. Okay. So I had a patient maybe, it was a couple of years ago, and he was a retired surgeon and very analytic in how he thinks, and he's about 80, and he walks on a treadmill 2 miles every day. He's been consistent about doing that. And he came in and said, look, I've lost the ability to walk the way I used to. And I said, well, what's wrong? And he said, well, when I get started, I can only go, a third of the time, and it keeps getting worse. I've lost the ability to do inclines. I can't do that anymore. Am I just getting older, and am I just, breaking down? And I think the bottom line is, I would say the body's the body, and if the physiology works, muscles work, everything tends to function, nerves function. So we did a basic ABI on him, and that was relatively normal. And we did a duplex and really found no lesions. So, Chad, what would you do next? What's the next step in your algorithm to this?
I'm going to guess that he came back for an exercise study.
Well, I think that would be a reasonable thing to do. And, it shows that he drops. He drops his pressure. So when we exercise, we should have a rise in our blood pressure. Isn't that right, Trish? Mm-hmm. She taught me 20 years ago in EVMS. I was a young baby doctor back then, and I didn't know anything at all, and so she yelled at me quite a bit. So I learned a lot from the pain of that. But so the exercise test shows that it dropped. It dropped to let's say 30 points, and so from 90% or ABI 0.9 to 0.6. So there's something wrong, right? Well, how do I know? I told you before, and I told my team, make me an operation. I'm a lazy doctor. I want you to tell me what's wrong so I can just go fix it. How would you tell me more information?
So if it was me, I would be asking, where is his pain when he's walking? Is it hip pain? That can be an indicator sometimes of an iliac process. Is it calf pain? That could be something in the legs, and try and determine if there's a certain zone that maybe we need to look at again, that we might have missed a small lesion or something like that based on his symptoms.
I think that's a good thoughts. Those are good questions to ask. He doesn't have pain. He just has weakness that develops. And I guess we could order a CT angiogram. I mean, that's only $3,000, right? And it's, the equivalent of 400 chest x-rays. Think about that. That's how much radiation you get. It's $3,000, 400 chest x-rays, and we use it all the time for people. But I'd like to think through some of these problems. Is there, Patricia, can you help him out? Help him, what do you do next?
Well, I think that checking out, you said there's no muscle weakness, no nerve issues, those sorts of things. Can they have a compression issue? I mean, are we looking at things in the popliteal space? Again, if it's calf, look at the popliteal space a little bit more closely. Is there any kind of compression going on there? And again, I think an exercise test to see what happens when, and did that, you're saying that the pressure dropped, but when did it, how far into it did it? And there has to be some physical impingement or problem, I would think,
Right.
rather than if you said aorta down, no lesions.
So I think that you're right. The physiologic test drops right away, and it takes 10 minutes to recover. So we know there's something physiologically wrong with that patient.
Mm-hmm.
That we know it is. How do we anatomically figure out where it is? And we tend to, it's good to do your ABIs, do your walking test, but you still have duplex, right? So you still have a duplex machine, and you can simply drop a waveform at the femoral level and tell me if it's an iliac lesion, because if it goes from triphasic to monophasic, then I know that it's the iliac above that level. If it's at the popliteal, and we do a duplex of the popliteal, and it's triphasic at the femoral, or maybe biphasic at that point, and then drops to monophasic at the popliteal level, it might give me a location of where that disease is.
And I think that combining, again, when we have I love the way one of our mentors to all of us, Marcia Newmeyer, always describes this whole scenario, especially with the arterial system, is a toolbox. You have a toolbox. If your standard tool isn't working, you have to look and see, what could I do to help? And I think that's an excellent suggestion, is then just to look for whether it's CW or duplex, what changes? Does the common femoral become disturbed, or is it at the popliteal? And that doesn't mean just phasicity, because it will become more hyperemic, but does it, what I call, shatter, or as someone in Virginia always said, their bubbling pot of a waveform when it gets very erratic.
Where I come from, a systolic drop in blood pressure during exercise is one of the hallmarks of left main disease. Mm-hmm. So I wonder, if you don't find anything with the duplex, would you dare to suggest that it may be a non-vascular or not primarily a vascular problem?
And you certainly can. And if you can't find anything, just say that whether vascular etiology is not indicated. Yeah.
Okay, thank you.
Yeah.
Are there any other questions?
Done.
Yeah, you gotta use my.
Okay, so if we do a full exercise study from rest to exercise and recovery, what's appropriate amount of time for that?
Appropriate amount of time scheduling for that?
Correct. Yes.
Well, the exercise would go up to, if it's on a treadmill, it's going to be different than if it's heel raises or toe ups, whichever side of the foot you claim that to be. That you would do toe ups for a maximum of 2 minutes. You have to make sure they can go up on their toes and that they're not just kind of bouncing a little. For a treadmill test, it would be 5 minutes max on the treadmill, immediate pressures, and then I think it is important to follow them out a little bit, 5-10 minutes, which again, if you're going to do this study, at least seeing do they start recovering in 5 minutes. That's then done. If they don't, does the surgeon want to know, does it take up to 10 minutes? And then you have to look at your LCD and your current, what protocols people use to say full recovery or not, because most of them do say, and following out to recovery.
So you get,
So I would give maybe another 20 minutes, 15 to 20 minutes for exercise. And this is what can make it so difficult to schedule these people, right? And I've been there.
All right. No, thank you very much. Is there any other questions? Oh, here we go. And I always, I'm telling the techs, make me an operation, because that process, that statement helps people to focus on how do we figure out how to fix this problem. And I think that's important for RBTs.
Yes, one of the questions I had is when we're ordering this test for a patient, you talked earlier about an algorithm. So if we order the exercise test and that comes back indicating more testing, do you automatically follow the algorithm, or do we need to order the conditional testing after the fact?
It depends on where you are. It depends on the internal guidelines. You will have to have an order, or there have been, and I learned this through a company I was working with where it's like, no, we have to call for another order. You do have orders that can read if this, then that. You have to make sure that you are following it well. And then as far as the timing, I remember a surgeon in Philadelphia when I said, well, it's really our schedule, because it would sometimes blow up into aortoiliac and at least down to the popliteal level with duplex on the spur of the moment. And I said, well, why don't we just bring these patients back? And I thought the room was going to just, it's like, I got a few expletives. It's like, you can't do that, fill in the blanks, people. And it was because you're in Philadelphia and you're in Center City, and they have to pay for parking every time they come, and it's a hassle, and they're not going to come back. Oh, well, then we have to plan it with enough people so that somebody can, that you don't know how long you're going to be in that room. And you have to do what Chad said. What essential, and what Dr. Lassar said, what essential information do I need to get so we can move on? But the conditional orders do work, and then it's a matter of timing. If I'm in a place where it's like, no, this is a small town, you can bring them back, it's not going to be a big problem, then you have to work more on the side of your tech's time. But again, I remember that moment well. I thought, it's like I had grown horns and turned purple. It was, what are you talking about? You can't do that in certain city situations. Or in New York, where I've been. It's, no, they're not going to come back.
All right, any other questions? Great questions. I think at this point we're scheduled for a break. I would encourage we'll be starting back at 10:10, so that's really about 15 minutes or so. But I'd encourage everybody to, restroom and coffee, they're still good there. We do have the vendors. Please stop by and see what they have. It's really kind of interesting technology, and they are supporting this whole event. And for the millennial and Gen Z folks and more enlightened older people, I'm one of those. There is a selfie stand up front, and if you take your picture, you type in your phone number, it will send it to you, and then if you want to put that out on social, it's hashtag Faces2022, just to get the word out. All right? Thank you.